We'll just finish stuff we didn't get to yesterday. So we talked about FEO, all the things we have to do. So congenital adrenal hyperplasia, this comes up, you know, clinically, we don't see it unless you do ped surgery, I think. But it always comes up on the test. So most common is 21 hydroxylase, salt wasting and virilizing. Second most common is 11 beta hydroxylase. That's probably all you need to know. The difference being that one is salt wasting, one is salt saving. And, you know, I think kind of having an idea of this picture helps. So you obviously don't need to memorize every little thing on here, but just kind of knowing the flow here of, you know, that aldosterone's over here, then cortisol, then testosterone. That kind of helps you understand why the different things do the different things. And these are all pretty rare, but these two are the ones to know. So 21 hydroxylase prevents things from going down here. So you're going to have a lack of aldosterone, but you'll have way too much DHEA and the sex hormone. So that's why that's why 21 hydroxylase, is salt wasting and virilizing, right? And then 11 beta hydroxylase is going to be, it's here. So it's, you know, you're able to make aldosterone and cortisol, but you can't get to this last step. So you're, hold on, is this wrong? Yeah, so you're still going to load up on DHEA, but you will have aldosterone. So again, it's just a difference between salt wasting and salt saving. I think that'll get you enough to get the question right, basically. So the 21 hydroxylase just prevents things from going down in those first two columns, so you don't have aldosterone. So I think just kind of having this basic picture in your head and knowing that 21 hydroxylase is here, you know, helps you remember not that you can't get aldosterone. So you're going to be salt wasting on that. This is from that New England Journal of Medicine paper, and it's, you know, I don't want to spend too much time on this, but it's just kind of a nice flow chart how to think about if you have an incidentaloma. So, you know, we've talked about this essentially, but you're going to get the hormonal testing right away, right? So you do a history and physical, get your hormonal testing. History and physical things are pretty obvious. So this is low dose DEXA, the urinary metanephrines, and then if hypertension is present, but I would say just get it anyway, and the aldosterone and renin, right? So that's going to knock out the three most common things to worry about, which is Cushing's, a FEO, and aldosteronoma. So once you've kind of, you know, figured out or not figured out those, then you move down. So if you have any of those positive, then you go to the confirmatory test, confirm what the mass is. Just remember. And then if those are negative, then you look a little closer at imaging. Excuse me. And so that's where the imaging things come in, right? So again, if it's less than 10 Hounsfield units and you have washout, then it's going to be benign. If other things, then you worry more about the you know, adrenal cortical carcinoma, a MET, or a FEO. But you just remember these two things, and you should be able to kind of clue in on which ones are benign appearing. And then again, if it's benign, we haven't talked much about this, but there is recommendations for surveillance. So if it's over 4 centimeters, this paper recommends surgery. I would say that's pretty safe now with MIS. Again, the number used to be 6, now it's 4. So over 4 centimeters, you can go to surgery. That says consider surgery, obviously, but and then if it's not over 4 centimeters, then you should repeat imaging, and they are recommending 6, 12, and 24 months. And, you know, there's different guidelines on this. This is kind of what I do, is every 6 months for a year, and then you kind of back off if everything looks good. And what you're looking for is growth, essentially. So if it grows over 1 centimeter at any of those intervals, then you consider surgery. So over 1 centimeter in a year is considered concerning. And then if it looks suspicious, you have to rule out FEO first, right? And then you can consider an FNA for metastatic disease. And then, you know, operate if you think it's a MET as well. So that probably melanoma METs are the most common. But anyway, if you're considered and if you're worried enough, either FNA or surgery. All right, questions about that? I think that's a useful flow chart to kind of have in your mind. I don't have two screens, so I can't really see you guys, but I assume there's no questions. All right. Ding. We've already talked about this. So ACC, let's talk about that briefly. So the biggest difference here is it's going to look ugly, right? So irregular, unclear margins, usually it's a little bigger. It's going to have the high Hounsfield units and no washout. So it's going to have those kind of concerning things. But this is probably the most characteristic thing, is that it just kind of looks uglier than these other things. So with ACC, Katrina, how do patients present who have ACC? What are the common presentations?
With ACC, probably a mass that's found on imaging that's large and ugly and scary appearing.
Do you think they produce hormones or don't produce hormones?
I think that they don't produce hormones.
So a lot of them do, actually. So oftentimes there will be a hormonal syndrome that they present with. So any idea which hormones they might produce?
I am going to say Cushing syndrome.
Yeah, so Cushing's is probably the most common. We'll go through it all, but they can do anything. That's the hard thing. It's kind of a trick question, is that they can produce any of these adrenal hormones, any of the cortical hormones. So, you can have virilization, you can have Cushing's. Pretty rare to have aldosteronoma, but you could have sort of a malignant aldosteronoma. Very unusual, but it can do any of those. But more common is virilization and Cushing. So let's just kind of run through this. So, this is very, very rare, but they say there's a bimodal presentation, either very young or over 50. And then these are the genetic syndromes associated with it. So MEN1 is probably the one that you'll be tested on. So, that's the tricky thing about MEN1, is that everybody thinks of the 3 Ps, but then there are kind of these other things that can come, and adrenal cortical carcinoma is probably like the next thing on the list. So if you want to get the 99 on the ABSITE, remember that 3 Ps and adrenal cortical carcinoma. Leaf-Brown-Maney, that can do a lot of different things, but adrenal cortical carcinoma is one of them. So symptoms, again, 40% Cushing's, 25% virilization, and then 10% both. So those are the most common presentations, is either virilization or Cushing's, or virilization and Cushing's, and then again, rarely they can do hyperaldo. So kids will often show virilization if they're young, and then you treat with a radical adrenalectomy. So you basically want to take any tissue out that touches it. It's controversial whether or not to do a nephrectomy. Most people would say no, but some people will do partial nephrectomies for these, especially if it's like stuck to the superior pole of the kidney. And then you want to get some lymph nodes as well. So you kind of take the periaortic lymph nodes that are nearby. And then Meg, any idea on medical therapy for this? It's kind of a random memorization thing, but anybody know the drug you can give adjuvantly for?
This is the mitotane, right?
Yeah, mitotane.
Oh, mitotane.
Yeah, it's sort of random, but so the things you can do adjuvantly if you're worried about margins, some people advocate for radiation. So when you take these out, usually you'll lay clips. And if any of your margins are close, you can radiate it. And then the mitotane is the basically the medical agent to try to keep these at bay. And then again, for symptoms, mitotane seems to work as well. But these are very, very rare, and I wouldn't, again, you'll probably never see one in your career, but those are the kind of the bullet points for the ABSITE more than anything. All right. So hypocortisolism, Addison's disease. Let's see. Bobby, how does Addison's disease present?
So you can get an Addisonian crisis, which is typically like shock or hypotension refractory to fluids and pressors.
Okay.
I guess more chronically, you'll have growth stunting, like the people won't, or kids won't, will go into puberty later, and I guess will be like salt wasting again.
Yeah, Alex
Just
says like
there'll be, adrenal hormone deplete.
yeah. So I think, the other things that are really common, right, is so if you have too much, what are you going to have too much of if you have hypocortisolism?
So
I think this came up in Krell's lecture briefly.
Are you going to have like too much ACTH? And so is that going to stimulate the melanocytes? Is that what you're getting at?
Yeah, exactly. So they'll have this kind of pigmented skin. I think I put this out of order. So anyway, we'll get to the presentation in a bit, but that's like on the, if you're going to write a vignette about Addison syndrome, it's going to be like muscle wasting, weakness. And then you're going to put something about pigmented skin, because that's like a telltale sign that it's not caused by that many things. So just remember probably that one, and you'll probably get the question right, is ACTH has this cross stimulation of the melanocytes. So you get sort of some pigmentation of the skin. What about causes of hypocortisolism? So you talked about a patient who has a crisis. Where does that usually present?
Usually in the acute setting, in the setting like withdrawal from steroids, that's why you have to steroid dose people intraoperatively who are chronically on them.
Okay, good. So that's mainly like an ICU problem, right? Or somebody who's, been on it for a while, and then you tell them to stop for surgery, like you said, and then you can have a crisis. So most common most common non-iatrogenic is autoimmune disease. So that's like with JFK, you can have autoimmune, Addisons, and then hemorrhage infection. So this is kind of like the, quiz question, Waterhouse Friedrichsen, which is a kid who has Neisseria and has meningitis from Neisseria meningitis. And then they have hemorrhagic, basically necrosis of their adrenal gland. So that's sort of a buzzword memory thing. All right. So the one other thing to keep in mind is that you can give dexamethasone and it will not mess with your stimulation test, which, to be honest, I don't work in the ICU that much. What are you guys being taught about hypocortisolism in the ICU? Do you just empirically treat it, or do you guys test for it?
Just depends on the attending. Some people, if their random cortisol is low, you can just start treating, and some people want you to do a stim test.
Okay.
So those are both university things. The current recommendation is to treat empirically.
And what do you treat with? Dexamethasone?
No, it's hydrocortisone or high dose glucocorticoids, because if you give a high enough dose, it will cover the mineralocorticoids. So it used to be that you wanted to give both. That's no longer the recommendation.
And so you're not going to test at any point then, because the old thing was like to give basically give the dexamethasone and then do the concentropin tests, because it wouldn't mess with your test. But if you're going to just give glucocorticoids, you're just treating. Does that sound right, Graham?
Yes.
Okay. All right. So this is really all I have left, which is just like, these are my kind of, again, the way I studied for the AB site was I would make these lists. I would have a piece of paper, I'd fold it in half, and then I'd write most common cause of whatever. And then on the other half of the piece of paper, I would write the answer, and then I would cover the answers and just move down the piece of paper. And I would do that, the day or two before the test. I think Tommy Brown has typed all these up, and they're somewhere on like some drive. So I would highly recommend just, 2 days before the test, spending some time memorizing all these most commons, because they're just kind of easy questions that you can get right, not overly complicated, and they're all over the test. All right, so let's go from the top. Kat, most common cause of Cushing syndrome.
Iatrogenic.
That sounds right. I don't really remember all these, so we're going to learn together. Yes, iatrogenic. Good. Second most common, cat again. So it's not iatrogenic. What's it going to be?
Like from an adenoma.
There you go. Pituitary. That can't be right.
I'm pretty sure it is. Cushing's disease is
Yeah.
more common.
Yeah, I think so.
Oh, I see what you mean. Okay, yeah. Okay, so in other words, you can have Cushing's syndrome caused by Cushing's disease.
Yes.
Yeah, okay. And then probably the third most common would be adrenal. So pituitary Cushing's more common than adrenal Cushing's. Sorry, I literally haven't reviewed these since we did this last year, so I'm probably gonna not know the answers, but all right, most common cause of congenital adrenal hyperplasia, Meg. So what's the most common congenital adrenal hyperplasia? Checking
Is
with
it-
the next to you.
I was asking Justin and he didn't answer me. I think it's 21.
Yeah, so 21 hydroxylase. What's second most common? These are the only two they'll ask about on the website, I think.
17.
No, 11 beta is second common.
Oh.
So, and what is, just quickly, what is 21 hydroxylase? What are you lacking when you have that deficiency?
The not the testosterone, the other one.
Well, there's three, right? Cortex has
Oh.
3 layers. So if you can't, if you don't have this enzyme, you can't get down here, right? So just
Mhm.
remember that there's 3, and I think of them in like this stepwise fashion. It's just kind of the easy way to remember this picture. So aldosterone, cortisol, and then DHEA. So if you can't get past this point, the only thing you can make is DHEA sulfate. So that's the most common one. It's going to be viralizing and salt wasting because you can't make mineralocorticoids. All right. All right, most common cause of primary adrenal insufficiency. Bobby, you already did Addison, so you should be all over this.
So iatrogenic withdrawal of steroids. Oh, that's
Primary, sorry. So that's a trick question. Primary, not, yeah, overall would be iatrogenic. Second would be
right, autoimmune.
autoimmune. Yeah, so that's, sorry, primary adrenal insufficiency. So just be careful if you read that question that you're paying attention to, overall or primary. I don't know. So all these that I wrote down are based off of like a question that I did or something like that mostly. So usually they're written in a specific way because that's the way I came across it in study material or a question. Most common cause of, or most common side of a extra adrenal pheo, Bobby. This we talked about yesterday, not in the thyroid.
The organ of Zucker candle.
Yeah, which is
Zucker.
where?
The aortic bifurcation.
Okay, good. Yep. Best localization study for a pheo. This is not up to date, but Justin.
So currently that'll be the DOTA, but this question might be going for like a MIBG.
Yeah, good. So just the question could be old enough, right? That DOTA won't be an option. In fact, that's probably what will happen on the test. So just be ready to always answer the answer that's like in the Pfizer book, which is old, but the website's old too. I think some people get like a little too caught up sometimes. And that's why, like, I've talked to Alex about this, you know, using CSAP to study for the website, I think is a little bit of a mistake because CSAP will also often have a question about like the latest, greatest, newest study on X, Y, or Z. And that may be too up to date for the website. And I think it confuses people a bit. So just be a little bit careful about that. So yeah, I agree. The right answer is DOTA, but on the test, it might be MIBG. All right, Justin, most common symptom of pheo. Just give me all the symptoms of a pheo.
So it's going to be headaches, hypertension, or sweating.
Yeah, good. So apparently the most common one is episodic hypertension, but those all sound good. All right, most specific test for a pheo. Specific, remember?
So it'll be the urine metanephrine,
Yeah, 24-hour urine. And why is that more specific?
because you can have sort of daily variations.
Good. Yeah. All right. I don't know. Oh, this was like a question on the test one year, which is why I wrote it down. It asked what the best test was. Any idea what the answer would be? Justin, what's your guess for the best test? Exactly, plasma epinephrine. So I have no idea why they said that was the best test. Maybe because it's the most sensitive, but it's definitely not the most specific. Anyway, but that was the answer on the test. So if you get that simple of a question, I would probably go with plasma epinephrines, but just be careful if they ask the most specific, it's going to be urine. All right, most common cause of primary hyperaldosteronism with a low renin. Justin, let's stay on you.
That would be aldosterone. The renin's low.
Yeah, so benign adenoma, 85%. What's the second most common?
It would just be adrenal hyperplasia.
Yeah, so bilateral hyperplasia. Yeah, good. So I didn't put that one in there, but yeah, that's the second most common. And then the third most common would be like an ACC, which is very, very rare, right? So the two are going to be an adenoma versus bilateral hyperplasia. So that's why you have to do adrenal vein sampling, because, 14, 15% is not uncommon for bilateral disease. Okay. Most common secondary cause of hyperaldosteronism. So the difference here, secondary, Lexi, let's go to you. Secondary is going to have a high renin, right? So this is, they try to rope you into hyperaldo, but then when you get the renin, that comes back high. So the ratio is not over 20-1. Lexi, most common cause?
CHF.
Yeah, good. So it's going to be CHF, renal artery stenosis, or what's that random tumor that makes renin? It's called Bartter syndrome.
That's right.
Never seen that before, but it's been on the test. All right. So CHF, renal artery stenosis, or a renin secreting tumor, basically. Okay, good. Best test to diagnose primary hyperaldo. Lexi, how are you going to diagnose that?
Renin to aldosterone
Yeah.
ratio.
Good. And the number is 20. Remember that number. And then the confirmatory test, salt suppression with 24-hour urine aldo. Apparently the number is 14 there. I wouldn't memorize that. I don't think you need to know that number, but that's the confirmatory test, is salt load with either high salt diet or saline infusion with 24-hour urine. Okay, if a patient has hypertension, high sodium, low potassium, what do they have, Lexi?
Con syndrome.
Yeah. Too quick. Yeah, that one's not hard. Best initial localizing test for an adenoma.
CT scan.
Yep, good. All right, Jess, these are probably too easy for senior residents, but anyway, most accurate localizing test for an adenoma. I don't actually know what I'm going for here. I'm just going to
Adrenal vein sampling.
yeah. Excellent. And what ratio are you looking for aldosteronoma?
You have to do the peripheral testing to make sure you're in the right location, and that has to be 3-1. And then you compare bilaterally, and it needs to be 4-1.
Good. Yeah. So over 4-1 is a positive localization. McCarthy, most common symptom of Cushing syndrome.
Abdominal striae.
Just give them all, because I don't know what I was going for here.
Abdominal striae, moon facies, overweight.
Yeah, apparently weight gain is the most common. All right. Treatment for an unresectable ACC. So we just talked about this one.
Miditane.
Yeah, mitotane. Okay, good. Spencer, best initial test for Cushing's.
I think you can start with the low dose suppression.
Yeah, I don't actually know what I was going for here. So just give me all the ways you can test for it.
You can do the random, you can do the urine 24 with an ACTH, and then you can also get the low dose suppression in the morning.
Okay, and then one more that we didn't talk that much about, but I think
Oh, the salivary one.
yeah, so evening salivary. So yeah, I don't know what I'm gonna guess. Okay, apparently the best is urinary versus midnight salivary versus low dose. So all the options. All right. So again, 24 hours is going to have the most specificity because, you know, it's going to decrease some of the daily variation, although low dose DEXA should do that as well, as long as it's done correctly. That's the one problem with the low dose is if they don't take the medicine right or you don't draw it at the right time, you might get a variable number. So that's where the 24-hour, if you're on the edge, 24-hour would come in. All right. All right, Spencer. So high ACTH and high cortisol that persist with high dose dexamethasone.
Most likely ectopic.
Yeah, good. What if it goes away with high dose dexa?
Then you have a pituitary adenoma producing ACTH.
Yeah, good. Good. So yeah, I would just kind of on the aldo and cortisol ones, just sort of memorize that axis and kind of what the different variations are, because it'll always come up. They love to ask endocrine questions. Most common cause of non-exogenous Cushing's high that does suppress, we just talked about that. So that would be a pituitary adenoma. How would you find a pituitary adenoma?
Brain MRI.
Yeah, good. All right. Most common cause of ectopic Cushing's that does
Small
not.
cell.
Oh, okay. So most common cause of the ectopic.
Small cell lung cancer.
Yeah. And what would you get to diagnose that?
Chest X-ray and a chest CT.
Yeah, I think I wrote it down that way because that was like the way a question was asked one year. You know, they gave you this thing, this scenario, and then you were able to figure out what it is. But then they ask, what's the, you know, best localizing test or initial diagnostic test? And the answer was chest CT or something like that. So, all right. Indications for FNA of a less than 4 centimeter incidentaloma after FIO is ruled out. Spencer, I don't know what I was going for here, but give me some reasons you might do an FNA.
The way it looks on imaging, if it's concerning.
Okay, and what's going to be concerning?
So like irregular borders, the size, the density greater than 10.
Okay, and then what about washout? Will it wash out or not wash
out? Concerning would be like less or like delayed washout with also less washout occurring.
Yeah, so less than 15% at 50% at 15 minutes. So that would be more concerning. Again, less fat, consistent with fat. I don't know what the hell I was going for here. Maybe melanoma or something. I really don't know. Okay, we did. All right, I guess we got it right. Oh yeah, history of cancer, specifically melanoma, would probably be something that might prompt you to biopsy an adrenal mass. But you got all the things. All right. Indications for surgery of an adrenal tumor. So what's the size indication?
I think we talked about it yesterday. It was like 4 to 6 kind of variable, but
yeah, I would say 4 in 2020. And then I don't know what else I was going for here. Let's see. All right. So complex, irregular borders, greater than 4 or 6, like we talked about, functional, enlarging, or positive FNA for another malignancy. Okay. I don't know why I put that in there, but best treatment for an adrenal angiomyolipoma. Graham, what are you going to do with this when you see one in Alaska next year?
Expectant men, unless it's symptomatic, like from pressure or mass effect.
Okay, yeah. So you just leave these alone. And what do they look like, Graham, on imaging?
Usually large, less than 10 Hounsfield units, and homogeneous. They look like fat.
Yeah, it looks like a lipoma. The one caveat I'll give you is that you could have an RP sarcoma that looks like this. So you can have a retroperitoneal liposarc that just happens to be next to the adrenal gland that can look just like that. So that's why I would surveil these at least for like a couple years. And if they're growing significantly, or if they have any component that looks like a D-diff liposarc, then I would probably take it out. That's more of a practical thing than for the absite. But all right, let's go back to the top. These are probably not chief level questions, to be honest. All right, David, talk to me about how you're going to treat once you diagnose a FEO, what your sequence of drugs is going to be.
We're going to start with alpha blockers like doxazosin before adding beta blockers as needed for reflex tachycardia.
Okay, do you have any idea, since you're a chief, what dose of doxazosin you give and how do you titrate it?
No, I don't know the dose. You titrate it to mild orthostasis and rhinorrhea.
Okay, good. Yeah, it comes in 2 milligram intervals typically. So you just do 2 milligrams once a day, then BID, then 4 BID, and you just kind of keep creeping up until you get your desired effect. Okay, so certainly alpha blocker first. The other thing that could come up is if someone comes into the trauma bay and they have a positive history for cocaine use, you should do the same thing, right? So but I don't know. I feel like that's come up before, but don't give a beta blocker right away. So yeah, Cardura, the phenoxybenzamine was the old answer, so that might be the answer on the test if it's an old question. Okay, back to Bobby. Oops, I just gave that one away. Less than 4 centimeters, round, homogeneous, less than 10 ounce field with washout. It's a benign adenoma. Leave that alone unless it's functional. All right, most common cause, hypotension, fever, lethargy, abdominal pain, nausea and vomiting, all these things. Bobby, what is that describing? Low glucose, high potassium.
Yeah, so I think we're getting at an Addisonian crisis.
Yep, good. And how are you going to treat that?
The hydrocortisone along with fluids and pressors.
Good. This is probably wrong. It's probably old. Dexamethasone first. I think this is based on the older stuff. So I would, who knows how old the absite question will be, but just keep in mind that this was the old answer. The new answer is to just treat with glucocorticoids, as Graham said. All right. Contraindications to laparoscopic adrenalectomy, Bobby. When would you do an open adrenalectomy?
So you need to do it in cases of adrenocortical carcinoma.
What's going to make you think that?
So again, any very suspicious imaging characteristics for if it's larger than 4, definitely 6 centimeters, regular border slow washout. And then
yeah, so I think that's the stuff that, again, this is all controversial now. So some people are doing ACCs, MIS, but the old answer and probably the absite answer is if you really are worried it's an ACC, just do it open. In real life, you don't necessarily have to, but I think that's all I have.